Hi everybody, we're going to talk today about nutraceuticals and nutrition and the role that it plays in pharmacology. Remember, nutrition and nutraceuticals is essentially looking at the nutrition or the foods that claim to have a medicinal effect. And this is a newer area of pharmacology, and when we're looking at more preventative medicine and being more proactive in our health, this is an area of pharmacology that has really taken off. It does have a lot less FDA restrictions, so it is something to be cautious of when patients are coming in with various vitamins and different herbal remedies. We have to always keep in mind that we're not as versed in these areas, and perhaps they're not quite as regulated. But we're going to talk about some of the standard items that you're probably a little bit more familiar with. Excuse me. So we know that food affects the GI absorption of drugs. If you have food in the GI tract at the time of drug administration, it will affect the gastric emptying time, so how long it takes for food to move beyond the stomach. It'll affect the concentration gradient as well as the absorptive surface area. So again, it is important to be aware of should a drug be given on an empty stomach or on a full stomach or with food. And again, we think about these things as nurses, but when you're the one prescribing, it's important, especially if you have a patient who is not eating properly, or somebody who already has delayed gastric emptying, which is so commonly seen with our diabetic patients, for example. So again, just something to be aware of. When we talk about the influence of diet on drug absorption, keep in mind that drug absorption takes place across the mucosa of the GI tract. So we see that the proximal portion of the small intestine has a large surface area, and it is responsible for a large role in nutrient absorption. Why do I say this? Well, think about patients who have had different surgical approaches. For instance, our patients who have had gastric bypass surgery, they're going to have a much different they're going to have a much different absorptive process than somebody who has not had gastric surgery. So when we talk about drug absorption being decreased, delayed, accelerated, or increased by food, we have to be cognizant of this because it certainly, as I mentioned in the last slide, will be important to how the patient responds to these medications. Also, food changes gastric pH, which we can see this as a problem for our patients who have gastroesophageal reflux disease or have a history of ulcers. So we have to be cautious about what foods they're eating in relation to different medications they're taking, such as, we've used this example before, something like an anticoagulant or an antiplatelet drug like Coumadin. Food combined with medication, which will also decrease absorption. We have a classic tetracycline and milk. You take those two medications together and you're going to have decreased absorption of the medication. Then we have the classic griseofulvin, which we don't use so much anymore, but we know some drugs are better absorbed with food, and that would be an example there. And my apologies for this slide set. It keeps pushing some of these words to the right, and I apologize. I thought I fixed it already. So please bear with me, but when we're talking about the influence of diet on drug metabolism, again, we were just mentioning on how it affects drug absorption, but when we talk about, and I will just say, again, absorption is altered depending on the presence of food, and that presence of food can increase absorption or decrease absorption. Fasting can also decrease absorption due to vasoconstriction. That's important when thinking of our hospital patients. High-fat diets, for example, will change the gastric emptying as well. So there's so many things to think about when we're talking about absorption. We have the classic Fosamax has to be taken on an empty stomach because it will become 40% less bioavailable if it's not. So I think we classically think about absorption and diet and how that affects a drug. When we talk about metabolism, we're talking about the rate of the drug being metabolized being affected by nutrient intake. So things like a low carbohydrate, high protein diet may increase drug metabolizing enzymes, so low carb, high protein. Antioxidant cruciferous vegetables can increase the activity of drug metabolizing enzymes. Classically, we think about grapefruit juice and the furanocoumarins and how they affect the CYP3A4. Not the same as the last CYP450 conversation we were having, but they affect CYP3A4, which is also quite well known in things like calcium channel blockers, cyclosporin, tacrolimus, and all the statin drugs. And I am so sorry for this very itty bitty statement here that says foods and CYP 1A2 or IA2, sorry. And that's again talking about those vegetables as well as caffeine and charcoal broiling, charcoal on like a charcoal grill, that can lead to therapeutic failure with any drugs that contain CYP 1A or IA2. I'm so sorry. When we discuss the influence of diet on drug excretion, we also have to think about how some foods can change the urinary pH, affecting drug excretion. So again, the half-life of drugs can be changed or altered by the urine pH, okay? So that's why that's important. So for example, gentamicin needs an alkaline environment to be reabsorbed. So gentamicin, yes, not a drug you're giving every day, but gentamicin is the reason we don't give it every day anymore is because it's a very tough drug, and we know that patients need this alkaline environment in order to actually reabsorb the drug. So foods that we know can alkalinize the urine: milk, vegetables, and citrus fruits. Foods that become acidic to the urine or acidify the urine: meat, fish, cheese, and eggs. And I could give quite a few examples, but I really just want to have the conversation of having you get used to this notion of how many different foods can alter absorption, metabolism, and excretion. We'll get more specific as we go through each classification of drugs down the road. So we certainly know there are drug-to-food incompatibilities, right? So the classic ones are the ones listed here. Coumadin / warfarin and vitamin K containing foods, right? Why? Because it'll equal therapeutic failure. MAOI inhibitors and tyramine containing foods, those fermented pickled type foods, will equal an enhanced norepinephrine synthesis, which can basically lead to acute hypertension, okay? Flagyl or metronidazole and alcohol will equal a flushing headache. I call it a flushing syndrome. It's headache, dizziness, abdominal pain, chest pain, and that's because of the alteration in alcohol metabolism that occurs with flagyl. Caffeine and CNS-related drugs, such as psychotropics, can cause treatment-challenging effects as sort of the caffeine levels go up and down. We'll see different psychotropic responses. So again, we sort of have these ups and downs with the psychotropics and caffeine as the caffeine is spiking in our body and being excreted. So we tend to tell patients to stay away as best as they can from caffeine. Alcohol can induce or inhibit the CYP450 system enzymes, and that would be concerning for hepatic failure. The influence of drugs on nutrients. So we do understand that there is something called drug-induced nutrient depletion. So things like antacid therapy or potassium therapy can reduce the absorption of folic acid, iron, and vitamin B12. So oftentimes when I'm seeing a patient with decreased folic acid or decreased iron levels or decreased vitamin B12 levels, there's a whole differential that goes into figuring out what the cause is, and multiple lab studies. So why does that matter? Well, because these are essential elements, essential nutrients in our body that can really lead to mental status changes. It can lead to absorptive issues down the road. It can lead to anemia that's symptomatic. I mean, we see patients hospitalized as a result of some of these depleted nutrients. So yeah, it is important. Dilantin reduces the level of folic acid. Loop diuretics, as we often are aware, are going to decrease sodium, calcium, and potassium levels. And why? Because it depletes them due to interfering with renal reabsorption. So how do you recognize drug to food interactions? Because pretty much you already have several things to consider in trying to just make sure you're prescribing the right drug in terms of the diagnosis and making sure that it's the right dose. So how do you now worry about all the drug to food interactions? Use sources like UpToDate. Use whatever sources that you have at the hospital or sort of built into your EMRs. Seek out educational materials that can provide accurate and appropriate drug information on patients. Don't be afraid to ask your colleagues, pharmacists, dietitians. Never underestimate the knowledge that registered dietitians have. They are my go-to on many of these issues. Get a complete patient profile in terms of drug and herb and nutrient intake. We don't do a great job of understanding what the over-the-counter herbs, vitamins, alcohol, nutrient supplements that our patients are taking. We kind of stop at the what's been prescribed, and when the patients aren't really aware, then we stop and say, okay, moving onward. So again, we don't have a lot of time to get that thorough history, and we should be, because I've found a lot of issues down over the years with going down the list of what's actually being taken by the patient on a daily basis or even on a regular basis. So in terms of nutritional management, again, consult with a registered dietitian. I can't tell you how much they have helped me over the years. Infants and children should have 400 international units of vitamin D daily. Women of childbearing age who become pregnant need 400 micrograms per day of folic acid. Pregnant women need 600 micrograms per day of folic acid. A multivitamin, a mineral supplement, 27 milligrams per day of iron. There's a lot of pregnant women who can only tolerate something like a Flintstones, and that's better than nothing. Again, some of the iron, I should say, some of the prenatal vitamins are just tough on the GI tract. They also need vitamin B12 if the patient is vegan or lacto-ovo-vegetarian, because they probably won't get enough vitamin B12 while being pregnant. Older adults, and I hate to say older is over the age of 50, but it is in this category. They need 2.4 micrograms per day of vitamin B12, and we need to ensure adequate intake of vitamin D and calcium. Again, recommending multivitamins for most individuals in the United States. Patients at risk for suboptimal vitamin D levels should consume vitamin D fortified foods or supplements. That's where the cereals are good, especially for children of who might not be getting proper nutrition otherwise. So let's talk about nutraceuticals. And these are the foods that claim, and we have to say it that way because we don't have as much evidence for nutraceuticals as we do for some other areas of pharmacology. So these are the foods that claim to have a medicinal effect on health. Fiber, vitamins, minerals, fatty acids, plant sterols, the pre, pro, and symbiotics, okay? So fiber, what do we use fiber for? Um, Well, constipation. And decreased fiber causes constipation in many, many adults. We see over 8 million office visits per year for constipation. And don't think I don't see it in the hospital. It's called constipation or obstipation. We see it in our small bowel obstructions. We see it in lots of patients. So, fiber, is not all equal. There are different types of fiber, but I will just say what I should step back for a moment and say what is fiber? Fiber is the term used to describe the substances in plants that the body can't digest. I know it's not really what we think of when we think of fiber, right? Um, yes, it can help lower cholesterol and can control blood glucose. Our goal would be 25 to 30 grams per day of a soluble fiber. And I can tell you the average American diet's about 5 to 10 grams of fiber a day. So we all could use a little more fiber on average, okay? Easy way to try to get somebody on a more normalized diet, more normalized bowel regimen would be increased water, increased fiber. Some patients you'll find just can't handle vegetables and fruits that easily. And things like Miralax, I mean, we use Miralax all the time. It's our colonoscopy prep, right? But a lot of patients don't need quite that. What they really need is to eat better and eat different foods. So, before you start going down the path of stool softeners and Miralax, you can always consider the basics, which is fiber. Let's talk a little bit about vitamins, equally important. So let's move forward to vitamin B3, which is niacin, sometimes a first-line treatment for mild hyperlipidemia or used to sort of prevent sometimes patients having hyperlipidemia. Certainly not considered to be as therapeutic as the statins, but a good starting point. You can always tell patients to, take plenty of vitamin B3 and recheck them in a month or two and see if their lipid levels are lower. Vitamin B6 is needed for platelet and red blood cell metabolism. Drugs like INH can cause vitamin B6 deficiency. You want to add vitamin B6 to pregnant patients' med list to also help decrease nausea and vomiting. And it can also decrease PMS symptoms. So again, some things we maybe don't think about with our vitamins, our essential vitamins. Moving onward to vitamin B12, it's essential for red blood cell formation and neurologic function, something I also will check in anemic patients that are having mental status changes. We have to always be concerned with vitamin B12 deficiency in patients with having had prior gastric bypass, those with decreased acid levels or celiac or Crohn's disease or strict vegetarian diets. You want to look for numbness, tingling of the hands and feet, and these patients will have a megaloblastic anemia as well as decreased appetite often. Megaloblastic meaning that it's not a microcytic anemia. Their MCVs are high. Vitamin C, ascorbic acid, as we also know it as. Has to come from our diet. We cannot synthesize vitamin C. Inadequate vitamin C may cause scurvy, and we don't really think about scurvy in the U.S. very much, although it can happen. Sort of classically, I think about scurvy. World War II, my grandfather was on a Navy ship for 6 years out in the South Pacific, and most of his ship had scurvy. Because they didn't have proper food out on the ship. the battleship to be able to have enough vitamin C intake. So what does that look like? It's fatigue, it's malaise, gum inflammation, which is kind of classic with bleeding. We do see it still with patients who smoke a lot and have poor ingestion of vitamin C. Smoking will decrease vitamin C levels. Vitamin D is critical to bone health, and again, we want to see 400 international units per day of vitamin D. You can check vitamin D levels with a blood test. It's serum 25-OHD to check for vitamin D deficiency or vitamin D toxicity. Vitamin K is a critical component of blood clotting. Again, we've talked a little bit about this when we talk about warfarin or Coumadin. And again, my apologies to with these slides. I'm not sure what happened. Deficiencies of vitamin K is quite rare. We actually see the opposite occurring in adults. It's interesting. I didn't pick up on something in your textbook that states that anybody with an INR greater than 10 should get vitamin K. Wow. We would give vitamin K for less than an INR of 10, especially if a patient is bleeding. So I just want you to know that that number might not hold true all the time. But I'm not going to ask you that question on a test. It's found in many foods, vitamin K. It's also synthesized by the intestinal bacteria that's in our body. Newborns need 0.5 milligrams to 1.0 ideally within the first hour of life to help prevent vitamin K deficiency bleeding. And that's where it's kind of opposite. We have our newborns that we worry about vitamin K deficiency. Again, for adults, it's more of an excess of vitamin K. So folate. Folate is necessary for the normal maturation and function of red blood cells. Folate deficiency therefore causes a macrocytic normochromic anemia. Oral folic acid is well absorbed and can be given easily this way. So easily you can give oral folate. And again, we talked about how it's important, especially during pregnancy and in women of childbearing age, teens, pregnancy, as mentioned, and lactating women. And I'll just sort of let you read the slide here. A couple more slides to go. Looking at minerals now, we have calcium, again, required for muscle contraction, blood vessel health, bone health, normal nerve conduction. Pretty extensive needs for calcium. Females notoriously are not getting enough calcium in their diets, especially adolescent females, so something to think about for those of you who are going to be FNPs. Iron is important. It's an oxygen transport mechanism that we have and needed for cell growth. Patients will develop a microcytic hypochromic anemia, so again, they have a low MCV. Iron deficiency anemia is a huge problem. It's one of the biggest consults I get on a regular basis is iron deficiency anemia. And between gastroenterology and hematology, it keeps us quite busy. So again, you really need to do some investigating to see if this is medication related. You need to determine, is the patient symptomatic? If they are symptomatic with their iron deficiency, that means they're not compensating. So this could be from a bleeding source. If they are well compensated, it could still be from a bleeding source, but perhaps it's a very slow bleed. And their body has been able to compensate. So again, iron deficiency anemia, yes, it's great if it's from a pure iron deficiency standpoint, and you can put them on something like Venofir or oral iron. But again, there's lots of reasons patients become deficient in iron. And for those of you who are acute care, we're going to be talking about this in our courses. I hope all of you will. Perhaps our psych NP colleagues will not need to address this in as much detail as we do. But please know it's not it should not be if you see iron deficiency anemia that you just give the patient medication with iron. You need to work them up thoroughly. That's my point. And rounding out this conversation, we have fatty acids to talk about, and then the plant sterols. So with fatty acids, there's the essential fatty acids that need to be consumed. They cannot be made by the body. There's a long list of them, such as the omega-3 fatty acids, the omega-6 fatty acids. There is some dialogue out there, and when we think classically about cardiovascular health and omega-3 fatty acids, but there's also conversation about looking at fatty acids as quote-unquote treatment of symptoms for autism. There was a study that looked at 500 milligrams to 1 gram a day of omega-3 for autism patients. So I think, again, just to show that there is some growing research in these areas of nutraceuticals. When talking about plant sterols, again, these are compounds found in plant-based foods. They're smaller in structure, they're similar in structure to cholesterol. They compete with cholesterol in the intestine, reducing the amount of cholesterol that is absorbed. So they're present in edible oils like corn oil, canola oil, seeds and nuts. That's why seeds and nuts are so important in reducing lipoprotein cholesterol. And again, the intake of about 2 grams per day of plant sterols has an equal effect of about 6 to 10% reduction in the LDL cholesterol. And lastly, pre, pro, and symbiotics. We could have a lengthy conversation about the differences between pre, pro, and symbiotics, but I'll keep it fairly basic. Probiotics are the non-pathogenic bacteria normally found in the intestinal microflora. So classically, this is why you're told to eat lots of yogurt back in the day, because that's all we had was yogurt. We knew that certain yogurts especially had more probiotics to combat against the effects of antibiotics. Remember, antibiotics, when you take them, or antimicrobials, do not care what they're sort of destroying, right? So they destroy the good bacteria as well as the bad bacteria. Now we're a little bit more sophisticated than just saying yogurt, and we have things like Lactobacillus acidophilus and Bifidobacterium species, and a list upon a list of pre, pro, and symbiotics that are available. We basically say that anyone who is on an antibiotic that has a functioning immune system, so minus any of your active transplant patients, we say anybody who's on an antibiotic should be on a probiotic, and we would also say they should maintain that probiotic for 2 weeks after stopping their antibiotic. It helps to decrease inflammatory bowel disease flares, your Crohn's, your ulcerative colitis patients, helps to decrease necrotizing enterocolitis, as well as the classic antibiotic-associated diarrhea. So again, there's plenty of options for patients to choose from that are over the counter with all of these items, but you as the prescriber need to help guide them in the right direction when it comes to nutraceuticals.